Hello everyone, I am Dr. Vijay, pediatrician at the Dr. Yevle Multi-Specialty Hospital for Children in Navi Mumbai. Today we are going to talk about dehydration and its prevention and correction using oral rehydration solution. Dehydration is defined as the condition that results from excessive loss of body water. And now remember, malnutrition and dehydration, they have a link. In malnourished children, diarrheal disease leads to dehydration. Dehydration leads to malnutrition. So it's sort of a vicious cycle. Any child who develops diarrheal disease has a risk of developing dehydration. Dehydration can also occur because of frequent urination, excess sweating, or vomiting. Now, this dehydration is corrected by oral rehydration therapy. Both WHO and UNICEF have recommended ORS to prevent or treat dehydration from diarrheal disease, irrespective of cause or the age group that is affected. So it can be used in any age group, right from birth to 18 years of age. Even an adult can take it. Now, if you look at the constitution of ORS, according to WHO and UNICEF, ORS is a product which contains 90 milliequivalent per liter of sodium with an osmolality of 311 millimoles per liter. And this has been found to be very effective without causing any adverse effect. WHO and UNICEF ORS has substantially contributed for significant reduction in mortality from diarrheal disease. For its maximum benefit, various steps have been undertaken to develop an improved ORS, either by modifying the amount of carrier used or reducing the osmolarity of the ORS solution to avoid possible adverse effects. However, the standard WHO ORS has an osmolarity of 311 millimoles per liter. The improved variety of WHO ORS is available with a reduced osmolarity to 245 millimoles per liter. An ORS solution consists of glucose, sodium, potassium, and citrate. Glucose is used because it facilitates the absorption of sodium and water on a 1:1 molar basis, and this happens in small intestine. Sodium and potassium are needed to replace the losses which occur during diarrheal disease and vomiting. Citrate used in the formulation corrects the acidosis that occurs as a result of dehydration. The four ingredients yield an effective ORS solution for rehydration. Now, certain ORS formulation replaces citrate with bicarbonate. However, in countries where the temperatures are extreme, say up to 60 degrees or so, with citrate containing ORS, there is no discoloration and a shelf life of 2 to 3 years can be achieved without any specific storage precautions or conditions. And citrate containing ORS is more stable than bicarbonate containing ORS. ORS containing amino acids or maltodextrin, when compared to standard ORS solution, was not found to be more effective in treatment of dehydration compared to a standard ORS solution. Then rice-based ORS, which is yet another type of ORS, was not considered superior to standard ORS solution in reducing stool output in treatment of children with acute diarrhea. Now, if you look at the efficacy studies which have been carried out on treatment of diarrhea with ORS, in acute non-cholera diarrhea, it suggested that the efficacy of ORS is improved if the sodium concentration is reduced to 75 milliequivalents per liter. If the glucose concentration is kept at 75 millimoles per liter and total osmolarity is maintained at 245 millimoles per liter as compared to 311 in the original WHO ORS formula. The need for unscheduled supplemental IV therapy in children given this solution was reduced by 33%, one-third reduction. When the data is compared to other ORS with lower osmolarity, that is 210 to 268 millimoles per liter, with little lesser sodium content of 50 to 75 milligrams per liter, the stool output was reduced by approximately 20%, and the incidence of vomiting was reduced by 30%. So the adverse effect of vomiting is less with low osmolarity ORS. This helps in inferring that 245 millimoles per liter ORS, that is reduced osmolarity ORS, appears to be as safe and effective as standard ORS for use in children even with cholera. In a randomized study, 153 subjects carrying out outdoor work on a summer day were randomly assigned to have ORS and their favorite drink. And what was analyzed was the fatigue. The degree of fatigue experienced immediately after work was analyzed using a visual analog score. The fatigue visual analog score was significantly lower for ORS group versus that in the favorite drink group. So these results also show that intake of ORS may be effective in reducing the fatigue associated with dehydration. Another study that included about 129 children with acute watery diarrhea and moderate dehydration. What it revealed was the initial observation of at day 1, 2 to 4 hours after hospitalization in emergency department, 79 out of 129 children, that is 61.2% of the children, had tolerated low osmolarity ORS pretty well. And upon follow-up on day 2 of the 79 children, nearly 80% of children had improved their signs and symptoms, suggesting tolerance towards low osmolarity ORS solution. So friends, WHORS are safe and effective for dehydration and prevention of dehydration. It is called the invention of the millennium, and it goes to save millions of lives of children with dehydration because of diarrheal disease. Thank you.